Welcome to yet another session of the Pathway to Excellence webinar series. It's good to see you on this platform, a platform that encourages collaboration and learning among its health facilities, districts for improved quality of health services. The Pathways to Excellence webinar series gives a platform to facilities to share success stories, best practices, but also it encourages collaboration and learning from each other. So the aim is to inspire growth in terms of provision of health services, not only health services, but quality health services. And through these platforms, we encourage people to get connected with others who are doing well, but also to reach out if you are doing something that you feel like the team here can learn from. So today's discussion, strengthening maternal and perinatal death surveillance for safer motherhood. So we'll hear from our colleagues from Phalombe District Health Office, how they have implemented MPDSR to improve the quality of health services. The ministry here with us, they'll give an overview and tell us what Minister of Health in Malawi is doing to prevent avoidable deaths in mothers and babies. But this process involves identification of the death, notification, and quantification and determination of the causes and their avoidability, so that we can learn from those incidents and improve our systems so that we prevent the preventable deaths. So without wasting much time, let me introduce our speakers today. We have two seasoned speakers. We have Lois Bires from the Reproductive Health Directorate in the Ministry of Health. She has been in this field for quite long, and she coordinates MPDSR at national level. But also we have Veronica Magondesa, the Safe Motherhood coordinator at Phalombe District Health Office. She will be sharing us the how Phalombe has implemented, so that we can also learn from the team there one or two things. But also from a program perspective, we can also learn from the ministry through the presentation from Los Bires on how the ministry is supporting the districts. So at the end of the two presentations, we'll have a session, a plenary session, where we'll give a platform to the team to ask questions, but also to share even your experiences from your own settings. So we'll be transitioning to the first presentation, which will be made by Rose Bires. So let me give a platform to Rose for the first presentation. Thank you.
Okay, so as the moderator has already said, I will be talking about the overview of maternal and perinatal death surveillance and response program in Malawi. And that's the outline of the presentation. I'll have introduction. We'll look at MNH indicator progress, basically looking at one major indicator on mortality for maternal as well as newborn. We'll also look at the MPDSR interventions that we are doing as Malawi. And of course, along the way, we also have bottlenecks. So we'll also look at some of the bottlenecks in running maternal and perinatal death surveillance and response. Then I will conclude. So in terms of maternal mortality ratio, Malawi, we have high figures. We are, in every 100,000 live births, we are losing 439 women. And this is far above the target for the SDG. As we know, by 2030, countries should reduce their maternal mortality ratio to at least 70 per 100,000 live births. And also in terms of neonatal mortality, we also have high figures for Malawi. In every 1,000 live births, we are losing 24 of the newborns. And as we look forward to 2030, our target is that we should be at 12 per 1,000 live births from neonatal mortality rate. And the same figure, we should be around 12 per 1,000 live births for the fresh stillbirths. So you can see that we have really a long way to go. So as a country, we've made some progress, but as we all know, for maternal death, one death is too many. If we look at this slide, we are looking at the progress that we've made, and this is the source of the data is the Malawi Demographic Health Survey. So over the years from 2000, we've moved from 1120 per 100,000 live births. And the last figure that we have is for 2015, 2016. We are at 439 per 100,000 live births. Of course, this year we expect to have a new figure when the FDHS of 2024 final report comes out. But we are just looking at some of the estimates, like recently the UN estimates, World Bank estimates is saying we are around 225 per 100,000 live births. But we are yet to see in the final report how far we've gone in terms of reducing maternal mortality. So what have been the causes for these maternal deaths? We conducted an analytical report for maternal deaths, analyzing between 2020 and 2022. And it found out that the top 3 causes for maternal deaths are maternal infection at 24.8%, and seconded by postpartum hemorrhage at 20.4%, and eclampsia at 13.3%. Of course, we also have other causes, the abortion, the ruptured uterus, and the others, but these are the two most causes of the maternal deaths. And looking at the maternal death causes, those that are associated with the pregnancy itself, but there are also other factors, we call them contributing factors or associated factors. And the same report also brought out that healthcare worker factors are at 85%. And in these health worker factors, there are a lot of issues. Highly the incomplete assessments, inadequate monitoring, poor documentation, and also delay in starting treatment. And if you look at patient family factors, they were around 48.2%. And the administrative factors, these are the issues of equipment, issues of transport, issues of blood, and this contributed 47.8%. And lastly, the traditional birth attendants or community factors were at 8.9%. And as I said, the source is the Confidential Inquiry Maternal Death Report, which was released in 2023, but analyzed data from 2020 to 2022. And in terms of child mortality, this is the trend that Malawi has. For For the neonatal mortality, is the one in blue, the lower one. If you can see the trend, we are also looking at the Malawi Demographic Health Survey. We've moved from 41 to 20 to 24. And that's the recent figure that we have, that we are still losing these babies. And if you can see the period between 2020 to 2024, we haven't made much progress from 31 to 24. And the other one is the under 5 mortality and also the infant mortality. But you'll see that the under 5 mortality we've made is the one in maroon. We've made much progress from 234, and we are around 48. So what is causing most of these newborn deaths? The top 3 causes, as you can see, is the green one, which is birth asphyxia, and is seconded by the neonatal sepsis, and also prematurity. So these are the top most causes of neonatal deaths. So for the program, we all know that most of these maternal perinatal deaths are preventable if we do the right things at the right time, and we are also vigilant in terms of responding to complications that may arise through birth process, or also or maybe even during antenatal and even after postpartum. And the MPDSR is really a vital component of any elimination strategy. It is a surveillance system, so we are counting numbers, and not only counting numbers, we need also to bring out the areas that are where we have gaps, and also at the same time put up action plans to tackle those issues. So it's not only about counting numbers. That's why we have the R at the end, that we should respond to the issues so that the next mother or the next baby survives. So, and again, it is a quality improvement initiative, because as we do the MPDSR processes, we are trying to pull out the areas that are not working well, the contributing factors, even the causes, and along the way, we are improving the quality of care, and consequently having better maternal and newborn outcomes. So alongside many interventions, we all know the WHO system building blocks. There are issues of human resource, issues of equipment, logistics and supplies, and also infrastructure. But these other programs, they also are very important, and one of them is this MPDSR system. So at national level, what we are doing is that we are there to provide policy direction, and by this, we have provided guidelines, the MPDSR guidelines of 2021, which is a revised version. And for the first time, it had included perinatal in there, because the previous one only was looking at maternal death surveillance and response. But the 2021 revision has included the perinatal deaths. And this guidance is what facilities are using to run the program in the districts and even tertiary hospitals. And the other thing is the institutionalization of MPDSR. By institutionalization, because we are counting numbers of maternal and perinatal deaths, this has to be at all levels. In the central hospitals, they need to do this, in the districts, as well as in our communities, even in the health centers. So that's the direction that we've taken. And also, as we program in MPDESA, we are also doing program evaluation. In 2021, we did an evaluation also to look at the program, where are our strengths, so what are the bottlenecks, how best can we improve on the program. So these are the issues, because this will make us also to know where efforts should be put. And another one is the production of analytical maternal death report. I think I showed earlier on the statistics on maternal death. This is also one of our key intervention, because as facilities do review, but at national level, we need to come up with a broader picture where our problems mainly lie in terms of maternal and perinatal deaths in Malawi. So this is our also key area. And as I said, the recent report was released in 2023. And we are supposed to be producing these reports every 3 years. Another area for the MPDSR is the digitalization of MPDSR data. We all know paper-based work is very hectic, and sometimes you may lose data. And if we are counting numbers, we may not have the actual picture. So the digitalization, we started in 2020 with support from our Liverpool Wellcome Trust, and all facilities, the districts, the central hospitals, we are provided with the gadgets oriented, and they are able to enter as such. The program achieved real-time data in terms of what is happening in the facilities. And also at national level, we are doing more of capacity building. MPDSR needs to, we have a lot of issues. People need to know the ethical legal issues. For example, in there, we support that we should do, there should be no name, no blame, because this is a quality improvement process. So people or committees in the facilities, they need to know these issues so that they have quality review. And again, because we are counting numbers, and we need also to be the same in terms of international classification of diseases. If a maternal death in Malawi is due to postpartum hemorrhage, it should be the same whether in Argentina or wherever. So these two, the MPDSR guidelines, as well as the coding, the ICD-11 for perinatal mortality, and also maternal mortality, should be very conversant with all committees in the facilities. Other than that, we are also into mentorship, and of late we have embarked on on-site mentorship, because we saw supervision was not enough. We needed to do on-site mentorship. And I'm glad to say, I think so far from last year, we've had at least 3 sessions. So we have a team of mentors on MPDSR QI. Of course, we also add on other issues like data, and also looking at the expanded like API. This is all in the name of integration. So it's not only about the MPDSR, but we have also added on to others. But we do take time out with the mentors. At least 2 weeks they are there in the facilities to support our colleagues at safe delivery level. So as we program, we also have loose ends that we need to tighten up. For example, we have gaps in perinatal death audits. Much as I said that as government or as ministry, we are there to institutionalize. But if we compare maternal and perinatal death audits, we have gaps in perinatal death audits, such that in some of the facilities they are not maybe prioritizing fresh stillbirth audits, which are equally important because it points out to quality of care in the labor and delivery room. So people differ. Some may just be auditing late NNDs, late NNDs, leaving out fresh stillbirth, but it's a thing that we need to institutionalize. And again, if we go into our communities where we do community MPDSR, also known as verbal autopsy, you will find that it's not being done in most of parts of the country according to the guidelines. And the other challenge, again, we also do experience backlogs, and this defeats the purpose of MPDSR because we need to learn from the situation in the shortest period of time so that we can act on the issues. So if a maternal death happens, for example, like today, and it's being audited 3 months later, then it doesn't serve the purpose. So this is also one of the problems that we are experiencing. We would need to audit as per guidelines, because for those deaths that occur in the facilities, we need to audit within 7 days. And for verbal autopsies, at least 2 weeks after the death occurs, the process should start. The other problem is the weak response systems. In all this, as I said, as we count numbers, it's not only about counting numbers, we need to respond to the issues. But you will find that most of the facilities, the same things keep on popping up at each and every death audit, which means our response systems are weak. And of course, mostly is due to maybe we are not vigilant. We don't put up a response coordinator as the guidelines say, because the response coordinator is there to help the team to chase what has been put in the action plan. And also sometimes it's about resources. We may want to implement something, but because it requires some finances, we may be able, or we may not be able to implement that one. So there's a whole lot. And also even the quality of the reviews. You would find that some of the responses, the plans that we come up with may not be the exact action that will actually completely remove the problem within our facility. So there are a lot of issues, and we really have to pull up our socks in terms of response part of MPDSR. The last one is that we do have hiccups in terms of digital, much as I said that we did digitalize, and even went further to in terms of sustainability, to link the digital platform at MLW with the DHIS2. But along the way, we also have these other hiccups, like maybe the gadgets in some of the facilities, they are not working, and they are also reporting manual as they did until that time that will be able to replace this. So these are some of the challenges that the program is experiencing. In conclusion, I would say that as ministry, with our partners, MNH partners, and all stakeholders, the commitment is there that we should improve maternal and newborn health outcomes, but it's everyone's responsibility, both at policy level, at service delivery level. We need to put together concerted efforts so that our mothers, our babies should survive, as well as thrive for the babies. So That's the end of my presentation. Thank you.
Thank you so much, Rol, for that elaborate overview of the MPDSR program at ministry level. So now transition to the presentation from Phalombe DH. I will now hand over to Veronica to take us through the presentation. Veronica.
All right, good afternoon all. As already introduced, I'm Veronica Magondeta, Safe Motherhood Coordinator from Phalombe District Health Office. So I'll just take you through what we have implemented so far for the MPDSR program, as well as the small steps that we have made and the success stories that we have been able to achieve as we have been implementing the MPDSR. So Phalombe district has a catchment population of 505,351. And the total number of facilities with maternity, we have 12 health centers and 2 hospitals. One that is Reverend John Chilembwe, and the other one is a CHAM hospital, Holy Family Mission Hospital. So for the data utilization, monthly we report over 1,730 mothers that attend antenatal per month, and 1,300 postnatal, or I should say 1,300 deliveries that we do conduct within a month, and 1,300 postnatal mothers that are registered or managed in a month. So the common maternal complications that we manage, they are postpartum hemorrhage, eclampsia, and puerperal sepsis. And we have already seen from the presentation of Mrs. Pires that all these conditions are also the leading causes of maternal deaths. So the state of MPDSR, before we started the MPDSR, we had increase in neonatal mortality. So for example, we could register over 137 neonatal deaths within a year. So there was also no follow-up of action points that were drawn during the maternal and perinatal death audits. So we had an increase in maternal deaths in the first quarter, that is of 2024-2025. That's from April to June. We registered almost 6 maternal deaths. So that was also another wake-up call for us. So as already said, the main objective of the MPDSR, or maternal and perinatal death surveillance and response, was to conduct quality and timely maternal and perinatal death audits and notifications and audits, including the near misses, with actions in order to improve on the quality of care that we provide to our women as well as our neonates. So for the stakeholders that we are being involved throughout the MPDSR is the local organization, which is InterAid, and this organization only supports 7 health facilities within our district. We also have a World Health Organization, which supported us in the MPDSR and the quality improvement mentorship in 10 health facilities. And the Operation Smile that also assisted us with the Help Babies Breathe training. So for the plans that we had was to revamp the MPDSR committee, to conduct data review meetings, integration of MPDSR and quality improvement, community involvement, as well as integration on maternal and neonatal health, as well as quality improvement and MPDSR mentorship session. So the initiatives that were implemented in the system to improve on the patient management and in the patient management and quality improvement was data verification. So for the capacity building, the MPDSR committee was trained with support from reproductive health directorates, mentorship sessions with support from ORT and InterEd, as well as the WHO, and the essential newborn care training with support from reproductive health directorate, BMOC, which is basic emergency obstetric and newborn care trainings. These were also done with support from the reproductive health directorate, including the International Classification of Diseases 11, version 11 trainings that were also conducted with support from World Health Organization. So the implementation timelines were to be implemented within a quarter as well as ongoing. So far, we have noted that there is a reduction in maternal mortality ratio, reduction in neonatal mortality, reduction in fresh stillbirth, and we'll be able to see all this in the presentation, in the slides that are coming forward. So the specific stories that we have registered so far, we have noted that more women with obstetric complications are being managed in our ward and are discharged alive. And another success story is successful implementation of quality improvement projects within our maternity units. That is 3 successfully implemented quality improvement at labor ward, as well as 5 projects in our nursery ward. So as I already said, we reported 6 maternal deaths in the first quarter, that is 2024-2025. That was also a wake-up call for us. So we had to work on the action points that we are drawing from the maternal death audits. So up until the last quarter, where we registered only 1 death. So for the neonatal death trend, I also extracted this one from the maternal MatServe platform. So we were also registering more neonatal deaths. That is from 2022 up until 2023, 2024. That's when we started conducting the perinatal death audits, and we are able now to reduce the neonatal deaths. So for the fresh stillbirth in the year 2023-2024, we almost registered 137, as I already said. But as of now, we registered 80. Of course, 80 is still a big number, but we have seen that there's improvement. And if we continue implementing the plans and the activities that we have already embarked on, we know that we'll be able to reduce it from 80 going downwards. So these are just the pictures of the pictorials of the activities that we've been conducting in the health facilities with the MPDSR, as well as maternal and neonatal, as well as the quality improvement mentors within the districts. And during even our mentorship sessions, we also included the students that are also available within our facilities, because we know that once they graduate or they qualify, they will be able to provide quality maternal and neonatal health care services to our women and the newborns. So far, the challenge that we've been meeting up is the malfunction of MatServe system server. It's up and down. So most of the times we end up using maternal death audit forms in hard copies. So the MatServe platform has already built in maternal and neonatal deaths that we're able to enter into the system. But because of that, we now resorted to the use of maternal death audit form, and that's hard copies. So we also have cross-border maternal and neonatal health issues with Mozambique. Most of their women, they report with obstetric complications, as well as they also contribute to the increase in perinatal deaths in our district. So on that one, most all the community midwife assistants now are in the health post, and most of them are within the borders with the Mozambique. So they are able to provide community-based maternal and neonatal health services in the communities, including the community engagement meetings where they offer the awareness on the maternal and neonatal health issues. So we also planned to have a meeting with Mozambican counterparts on cross-border issues that also include maternal and neonatal health. And this one is also in the pipeline because the Director of Health and Social Services, as well as the District Commissioner, they have taken this up. So the inconsistent mentorship sessions due to lack of funds. So Phalombe doesn't have any implementing partner, but still we are able to do the mentorship session. So the WHO only maybe comes within a quarter and the other quarter doesn't support, including the inter-aid, it supports this time, and the other quarter it doesn't support. We end up only mentoring few facilities within our district using the ORT. So that's also another challenge that we meet. So for us to sustain the gains that we have already embarked on, we are still implementing maternal and neonatal health quality improvement projects within our maternity departments, so that we should be able to work onto the plans or the findings that we get during maternal and perinatal death audits. So the commitment of MPDSR members, we make sure that we still motivate them. The DHMT is always supportive, just with maybe a drink. They do support with some drinks during death audits or perinatal death audits. So that's also another plus, so that the committee members are always motivated. So we are also continuing with maternal and perinatal death surveillance and response, quality improvement, as well as maternal and neonatal health mentorship sessions that we have already embarked on, and we hope to improve on the quality of care that we provide to our women. So another, the community involvement or the patient involvement, we've been involving the community leaders such as Paramount Chief Kaduya, as well as Hospital Management Committee. We give them the feedback on the findings that we get. We also give them the data. They are able to see how many deaths, maternal deaths have we registered, how many perinatal deaths have we been registered. So what actions are they supposed to take in order to support us in reducing these deaths? So there's also good coordination with CPMNC coordinator, community health nurses, community midwife assistants, as well as the HSAs. So as we can see, that's the MPDSR team giving showing how our data is going on with our senior chief or Paramount Chief Kaduya in our district. So far the lessons that we have learned that teamwork really helps, because reducing maternal and perinatal death is not only one man's job, but it needs teamwork. Use of data for action. We were able to review our data and see where we are, and then we came up with the plans of reducing the maternal and perinatal deaths in the district. As well as the client experience of care, we're also able to get to know on how we've been able to provide our care to the women as well as the newborns. So far, the recommendations that I can make to other facilities, I know we haven't reached up there, but I know we have taken the right path. And if they also take this path, I believe they'll be able to reduce maternal and perinatal deaths. So there has to be response to maternal and perinatal death audit action plan that they draw. The integration of maternal and perinatal death surveillance and response, as well as the quality improvement. They should also intensify on mentorship other than supervision, because mostly we do conduct supervision without mentorship. So mentorship, they also assist the midwives to gain the skills, knowledge, as well as the attitudes that is needed in provision of MNH services, as well as engagement of community leaders as they are providing their services. So the next steps that we are taking, we are still going to intensify on mentorship. We formulated the MPDSR committees within the health facilities, and only 70% are able now to conduct perinatal death audits within the health centers. But we are also planning on rolling out to other remaining facilities. So we are also planning to recognize the best performing departments or the health facilities so that they should be motivated as they conduct maternal and perinatal death audits, including the community engagement meetings. That is also our next step. And the other thing that I forgot to mention there is on the meetings, cross-border meetings with Mozambican counterparts, because I've already said we reported 13 maternal deaths, but 6 of them were from Mozambique. So we can see how much Mozambique is now contributing to our data. So we acknowledge the champions and the commitment of the district health management team, the MPDSR committee members, the maternity staff, as well as the stakeholders that they have been assisting us, like the InterAid, WHO, RHD, and the Operation Smile for making it happen. And I believe this will also continue so that we reduce our maternal and perinatal deaths in the district. So thank you all for your listening as I was presenting. So that's our DHSS, who is, and the other DHMT members who are always committed whenever it comes to maternal and perinatal death. Thank you.
Thank you so much to Veronica and Rose for those wonderful and insightful presentations. It was very interesting to hear and learn how MPDSR is being implemented in the country and how it is being used to avoid preventable deaths in neonatal babies and mothers. I think it was also interesting to see how maternal mortality has decreased over time in Malawi for the past 25 years. But as Rose said, one death is one too many in these instances. So looking at how neonatal mortality and under 5 and infant mortality has decreased in Malawi was also very encouraging to see. So a lot of these deaths are preventable, and we can see that MPDSR is a QI initiative, and you pull out the areas that are not working well and improve the quality of care to improve the maternal and newborn outcomes that we have in the country. So when it came to Veronica's presentation, we looked at what has been implemented at Phalombe DHO and what has been working well for them. So it was also very interesting to see how they involve community leaders such as the paramount chief and other community leaders that they have to improve maternal and newborn outcomes in their area. And I also want everyone to think about how, I'm going to use the term, it takes a village. So in this instance, what I'm trying to say is that to improve these outcomes, it's very important for different stakeholders to come together. And in the presentations, we saw that there were different stakeholders that were supporting the MPDSR initiative at district level and at national health level. So we saw that they work together, they work hand in hand with WHO, Malawi Liverpool Welcome Program, and other stakeholders. At that, I just want everyone to think about what they've learned, the lessons that they can learn from the two presenters, and how they can implement these in their facilities going forward. Thank you very much. Charles, over to you.
Thanks, Beauty, for summarizing the two presentations. We will now open the floor for questions or comments. So we have a hand from Hannah Tentani.
Thank you very much. First of all, I just want to thank the presenters for the good presentation that they have brought forward, which is really good, and I've learned a lot. I just have a question for Phalombe. You mentioned about having 4 maternal deaths, especially from Mozambique, and I've seen the strategies they are using to address these issues. So what are they doing about Mozambique as they are bordering with it? How are they managing this issue that they presented? Thank you.
Thank you so much, Hannah, for that question. So we'll take three hands, then we'll give a chance to the presenters to respond. So, Paul, you have the floor.
My question goes to the safe motherhood for Phalombe. Mostly, I'm so interested with the engagement of the Paramount Chief Kaduya in the safe motherhood activities. Just as a matter of learning, may you share how really you managed to have the whole Paramount into the MPDSR activities? Because I think this side, we sometimes tend to have more challenges because you consider issues of maybe the logistics. You sometimes think about the power that he has, and sometimes it becomes very challenging to sort of approach him. Can you share how you really manage to have him into the safe motherhood issues?
Thank you so much, Paul, for that question. We have another hand from Oveka. So once we take that one, we'll give a chance for the presenters to respond. Oveka, you have the floor.
Thank you very much, Charles. Just to say thank you once again to the presenters. The presentations were very insightful. My question is for the Safe Motherhood Coordinator for Phalombe. I'm just really intrigued to understand how they followed through following the death audits. As it was said in the presentation by Rose about the response part being very weak. So I just want to learn more on what were the enablers of them ensuring that they followed through the action points from the death audits. Thank you.
Thank you so much for the 3 questions. I will now give a floor to Phalombe DHO team to respond.
I can start, Madam Coordinator. She's not alone.
Yeah, please proceed.
Okay, so thanks for the 3 questions. The first one asking how Phalombe responds to Mozambique MDs. I can tell you that when it comes to cross-border maternal death, it's a quite challenging task to the DHO team. For example, we know that for Mozambique on the Phalombe side, of course, I haven't been maybe to the part of Mozambique, but we are told that facilities are very, very far to the Malawian border. So most of the times, even to engage with authorities from Mozambique, it's a daunting task that as a facility we haven't done. Much as we normally plan to engage the DC so that we also engage the DC from the Mozambican aspect, but it has been a challenge. I would propose that LHD takes lead in doing this. I'm saying this from my experience last year when I was in Malawi. We had the a meeting with colleagues from the API department. We went to Mozambique and we to do with cross-border cholera, polio issues. So I think LHD can also emulate the same, because from the national level, it will be very easy. But at district level, to say the DHSS and the DC to organize a meeting with counterparts from, let's say, one of the provinces, that side, might be challenging. So I would beg Madam Bires to say LHD should take lead on this aspect. It's worrisome because most of the cases that will come to Phalombe, they will be in a terminal state. As such, they will raise our number of MDs. Sometimes it might be a true reflection to say 6 MDs, but maybe for the institution, maybe you had 3, but the other 3, they are from Mozambique. So Madam from RHD should assist us in organizing these cross-border meetings. Otherwise, at district level, we've been singing this song for a long time. But for our colleagues from the API, we went to Mozambique because they had organized that meeting at national level, and we had met provincial authorities in Mozambique. On the second question, you wanted really to know about community engagement aspect, how it impacts the response to maternal death and even neonatal death. So one thing about Paramount Chief Kadoya, you know, she's a cheerful lady, and if you have an issue you want to talk to her at any time, she's quite open. And if the issue is pressing, once you tell her, she'll even tell you that tomorrow, the other day, I'll organize a meeting to call all chiefs. Because for her, health is the #1 priority. So because of that, we normally leverage on that aspect, that much as, yes, we're talking about powerful, but when it comes to issues of health, for her, she takes that at #1. So to us, we are privileged. It's very easy. You tell her today, Madam, we're having these challenges. Can you assist us? She'll tell you blank. I'm calling the traditional chiefs or village head chiefs to tell them about this issue. So that has been quite helpful. The last thing about death audits. So what we planned is that whenever there's a maternal death, sometimes we should not wait up to a week or 2 weeks to audit. If a maternal death happens today, tomorrow morning at least we need to have a summarized case by the team that were on duty to the morning handover. So we are serious on that part, and everyone knows that the moment we have a maternal death, we need to have a summary report. Then the next Friday, the same Friday, same week or the other week, the team has to meet and audit that death. So that has been happening constantly. That is what is helping us to do this. A comment from the questions. Capacity building has also shown that has contributed quite a lot when it comes to prevention of maternal death and even the neonatal death, because we have seen some pictures of the coordinator and the team moving around the health facilities. So as we can see now, the capacity building has really helped. But Madam mentioned about the weak response system. That is a challenge, especially to us as Phalombe. Why I'm saying this, when it's come to the referral system, because for now, you go to one of our health centers, a nurse or a midwife will really know that, okay, this case needs to be referred to the district health office. From the mentorship, from the coaching sessions that were done by the team. But now, let's say for the district to respond, I'll just add an example. Maybe you don't have funding, maybe for a month or 2. You can't send an ambulance to that facility. So still, that comes in the response aspect when it comes to maternal and neonatal death. So that also goes across even to the team that works in nursery, is also doing a commendable job because of the mentorship sessions that have been happening all around. So that were my short responses to assist the Madam Coordinator. Thank you.
Thank you so much, Phalombe team, for those responses. So you've highlighted the issue of cross-border clients, and I think from what you have said, I think with the team at RHD, that has been noted, I think can be discussed further. But also the issue of Paramount Chief Kaduya. I think you've highlighted the issue of her personality, but I think what we can also learn from this is to give it a try to the rest of the districts, because I believe that she's quickly to move in because there is something convincing. Is it the data that you tell her, you show her? Is it how you approach her? Is it so? That's what I think other districts can also emulate as well. Having, data is power. Once we have the data and approaching the gatekeepers like the senior chiefs, I think we should have a positive response. And you have also acknowledged challenges in terms of response. There are things that you are doing as the team, but also the other that require resources which have been challenging to you. Thank you so much for those responses. We are 2 minutes after the time we intended to finish, but I think we can take another set of 3 questions, then respond, and we'll be concluding our webinar for today.
Yes, Chair, I have my hand up. This is Dr. Phalombe from WHO. Main is majorly really to appreciate the team for organizing this webinar, and we hope we can have many more webinars in terms of setting the schedule, and for the districts really to respond to the call on integrating QI and MPDSR. What we look out for is really the sustainability approaches. How does the picture look like without the mentioned partners? Momentum used to be a very good collaborating partner, and without them, really, we find there are white summer gaps to fill. And remember, or recall partnerships really are the way to go. So even the districts and the ORT, kindly we request that you are also a partner to the ORT, that these interventions can really remain. Thank you, and over.
Thank you so much, Dr. Phalombe, for those remarks, and also for sparing some time to be part of this webinar. So I think you've raised a number of good points regarding the platform to give facilitators this opportunity to share and collaborate, but also leveraging on the resources within our districts side of the partners which have been mentioned, in order to ensure that these initiatives are sustainable beyond partners. Thank you so much, Dr. Phalombe. Any other hand?
Just to add up on the response part from the question that Oveka had. The response part has been challenging all along. So some of the interventions that we did, we chose a response person. This is somebody who will be following up all the action points that have been drawn from the audits. So whenever there are action points, this person is responsible to follow up to the responsible people who are can assist with that action points. And then during the MPDSR monthly meetings, she gives feedback to the committee on how the action points has been implemented, or whether there are challenges or not. But then the major challenge still remains, which Rosemary said, in terms of resources, whereby maybe you plan an action point, so sometimes we fail to plan because of the limited resources that are there, or if we plan, maybe it fails to be implemented because of the limited resources on the ground. Yeah, that's what I wanted to add on the response part.
Thank you so much, Phalombe team for that addition, but also for the good work that you are doing. So this concludes our today's discussion on strengthening maternal and perinatal death surveillance and response. So as it has been presented by the RHD, we can see that improving outcomes for mothers and babies is a priority for Malawi as a country. And it now takes all of us to ensure that we are doing something to contribute to this priority. So Phalombe is doing their part. It's not only Phalombe, there are a number of districts doing well. Only that in this single webinar, we couldn't bring everybody else, but I'm sure one or two things we've been able to capture from what has been presented. The issues of community engagement have come as a highlight on what Phalombe is doing. The issues of capacity building, but also use of a response person to ensure that action points are being acted upon. So let me thank everyone else for sparing your time to join this webinar. I think in the chat box, there is a link for an evaluation for you to evaluate this webinar so that next time we can improve here and there. So we rely on your feedback to ensure that the next one comes out better than this one. Reaching this far, I'll urge you to complete the form through the link which has been posted in the chat box, but also it will be sent to the email addresses which you have used to register for this webinar. Otherwise, we wish you a very good evening as we conclude this webinar. Thank you so much for joining.